You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City. Today is July 27, 2026. We will be discussing dermatology for the allergist. This is presented by Dr. Mark Serota from Epiphany Dermatology.
Thanks everyone for having me today. So that's the first thing I did when I finished my dermatology residency was I took my dermatology boards and then I sat down and made a talk called Dermatology for the Allergist, and then it's just evolved over time. Because I did my allergy fellowship first, and I realized that there were conditions I knew really well, like atopic derm, chronic urticaria, allergic contact, but then there were conditions I really didn't know much, if anything, about that are mimics of the things that we see a lot in the allergy office. So the idea is, can we become more familiar with the differential diagnoses of the things that we see a lot of, so that we know when a red flag comes up, when something is not following the usual pattern for atopic derm or something that we see a lot of? Will we know what mimics to look out for, what they look like, what signs and symptoms to look out for? So that's what this talk is designed to do. These are my disclosures. None of them are particularly relevant to this talk. I might mention a treatment here or there, but it's really designed more to expand your differential diagnostic capabilities. And like I said, I was an allergist first. This talk is designed to be a mile wide and an inch deep, meaning we're not going to take a deep dive into any particular condition, but rather to make sure that you're familiar and aware of these mimic conditions for the things that you see a lot of in the allergy office. If there's a particular condition that you find interesting or something within the derm allergy overlap realm, I'm always happy to give a talk specifically on that. I like many of those topics, but this is designed to be more of an overview, and again, to get you thinking about what other conditions are out there that I should be thinking of that are common, but maybe not common to the allergy office. So we're going to focus on a few things, 3 specific things. One is diseases related to atopic dermatitis. So the person has atopic dermatitis plus something else. The second is mimics of allergic disease, something that looks like an allergic skin disease but actually is not. And then the third are skin diseases that you just can't miss. And there's not too many of those, but when they walk into your office or when you're consulting in the hospital and you see one of them, you really have to get it right the first time, because otherwise bad things can happen for the patient. So we're going to review proper ways to describe skin findings. We're going to discuss commonly encountered skin conditions, again, focusing on the mimics of allergic disease. And we're going to understand some of the dermatologic treatment options and diagnostic modalities for some of these diseases. So we will not focus on atopic derm, allergic contact, irritant derm, urticaria, and drug rashes. I like all of these things. I give lectures on these things. But again, you know these very well yourselves, and you see them probably almost on a daily basis in your office. So we're not going to focus on these for this particular talk. So first, if you had a heavier talk this morning, or a very science-based talk, or a lot of cytokines or T cells, this is going to be a lot more relaxed. It's a lot of photographs, and it's a lot of diagnostic and differential. So it'll be a little more relaxed talk for you. These are the tools of the trade that we use. Hopefully you're familiar with most of these. This is a dermatoscope where we can zoom in and look at lesions with magnification with special types of lighting. This is a shave biopsy tool. This is a punch biopsy tool. If you're not familiar with performing skin biopsies, I highly, highly encourage you to attend one of the workshops at the American College or the American Academy of Allergy meetings. I used to run, or not run, but I participated in both of those. I used to do the college one up until recently, but I highly encourage you to do that. I think it's the only sessions at that whole meeting that probably get like all 5-star reviews. Like literally the average is like the highest it could possibly be, because everyone leaves knowing how to do a skin biopsy, and everyone leaves feeling comfortable that they can actually do it in their office. Not to mention it adds a secondary revenue stream if you are in private practice from a business perspective as well. Plus, if you need to take a biopsy, the time to take it is when the person's sitting in your office and their rash is really active. If your idea is, well, I'm going to send it to the dermatologist to get a biopsy, most likely the rash will change, or it may have been treated, or it's not going to be the same as when you're seeing it in real time. So a lot of good reasons that an allergist should do a biopsy. And then this is called dioscopy, where you can press a microscope slide on a rash, see if it blanches or not. That can give you some diagnostic information. So there's 2 broad concepts in dermatology. It basically breaks down to two things: growths and rashes. Okay. And half of dermatology I crossed out there for you because you don't have to worry about skin cancers or growths of lesions on the skin. We care more about rashes. That's what we're going to focus on. But before I do that, this might be the most important slide of the whole talk, even though it's not what we're going to focus on, because you could save someone's life if you're examining them and you see something that looks like a melanoma. So melanoma, think about A, B, C, D, E, asymmetry, irregular borders, multiple different colors, a diameter greater than 6 millimeter, which is about the size of a pencil eraser, and evolution, something that's growing or changing over time. If you don't remember any of that, remember the ugly duckling. If there's something on the body that's very different than any other spots the person has, be concerned about that. If they have similar looking moles, they're oval, they're uniform, they're browns, they're light brown, that's fine. But if they're doing some of these things, send it for a referral to a dermatologist. And if you think this is just pie in the sky, I gave this talk probably like 7 or 8 years now to the Colorado Allergy Society, and it was a room full of allergists in Colorado. A week later, one of those allergists referred this patient to me. She had this lesion near her eye that was diagnosed as melanoma. Fortunately, it was picked up early by their allergist, and it ended up being excised, and she did fine. Had that not happened, this could have went deeper. This could have went into the eye and caused real problems for this patient. So remember these slides. Just while you're doing your exam, while you're looking at their body, while you're looking at their rashes, if you happen to see something like this, just be aware of it. So how do we describe skin lesions? If you do a really good job verbally describing skin rashes or skin lesions to in your notes or to a dermatologist, I can pretty much tell you what the person likely has, or at least give you a very good differential of it. But I find frequently physicians in other specialties that are not dermatologists, they use kind of layperson speak to describe rashes, or they don't use the proper adjectives when describing skin lesions. So let's just go over it. And you have primary lesions, and then you have secondary lesions. So the primary lesion is the noun. Secondary lesions are basically the adjectives. So you could say, for example, a crusted papule or a scaly plaque, etc. So I won't have time to go over all these in detail. I suggest you do read up a little bit on these, or these days just have AI explain, give you a summary of how you can describe the common skin lesions. It'll make you a lot more confident when you're doing dermatology things in your office, and you'll be able to describe them well. But I'll go over the basic ones. So a macule is a flat change on the skin. It's less than 1 centimeter and you can't feel it. So something like a solar lentigo, like a sunspot, would be a macule. A patch is the same exact thing, except it's greater than 1 centimeter, so larger, like a cafe au lait spot. A papule is the inverse of that, so less than 1 centimeter, so it's the inverse of a macule, but you can feel it. It's raised off the skin. Macule less than a centimeter, you can't feel it. Papule less than a centimeter, you can feel it, like molluscum here is a papule. Here's a plaque greater than 1 centimeter, so something like psoriasis or eczema. So you should be using the word plaque all the time in your notes, right? Erythematous scaly plaque, okay? If I said to you, erythematous scaly plaque bilaterally in the antecubital and popliteal fossa, I wouldn't even need to show you a picture. You would already know that that's eczema, right? Or if I said salmon-colored erythematous plaque with white or silvery scale on the elbows and knees, I wouldn't have to tell you anything else. You already know that person has psoriasis. So just by giving good descriptors, you can kind of say what it is. A vesicle is kind of like a papule because it's less than 1 centimeter and you can feel it, but vesicles are fluid filled. So an example would be this cluster of vesicles for HSV. How might I describe this? Perhaps a cluster of erythematous vesicles with an erythematous base, something like that. Bullae, so these are circumscribed, fluid-filled bullae that are greater than 1 centimeter, and they can either be tense or flaccid. So tense would be tense and tight and filled up like this. Flaccid would be the opposite of that. These are pustules, so these are circumscribed, elevated lesions that contain pus. So you might call these papules, but these are pus-filled, so they're pustules, versus these, which are fluid-filled, so they're vesicles. Okay, now there are others, but those are the big ones that you're probably going to use a lot. If all you use was papule, plaque, macule, patch, and then use some of these descriptors like erythematous, scaly, lichenified, crusted, then I think you're in really good shape in the allergy office. Now, there are certain patterns of rashes I want to quickly go over, and there are many different types. I don't have time to go over all of them, so I would encourage you to look at some of these yourself. But I want to highlight a few that are relevant to you. The first is called the Kebner phenomenon. So similar to dermatographism for urticaria, where you can essentially stroke the skin and basically write words even on the skin with urticaria, dermatographism. The Kebner phenomenon is a similar idea where trauma or scratching the skin elaborates the rash, but it's seen in inflammatory rashes like psoriasis or lichen planus. That's called the Kebner phenomenon. And then there's distributions like dermatomal distribution, which you've probably heard of, which follows along the roots of nerves. A common example of that is herpes zoster, shingles, where you get the clustering of vesicles on an erythematous base, but it's in a dermatomal distribution. And of course, dermatomal distributions are unilateral because the nerves come out of the spine and they go one direction or the other. So it usually is along one nerve and not the other. And I would also highlight that if you have a patient that is complaining of something in a dermatomal distribution, that could be itching, that could be pain, that could be them excoriating at those areas. If it's dermatomal and unilateral, ask yourself what's going on with the nerves underneath. I've seen people like literally they say it's psychogenic, it's neurogenic itch, they're crazy, and actually they had something compressing on their nerve like a tumor, but they were told, hey, stop picking at your skin all the time. If it's in a dermatomal or unilateral distribution, think about that. There's also another form of distribution that you might be less familiar with called Blaschko's lines. So this traces the migration of embryonic stem cell development. So it's not dermatomal. For example, it's more of a V shape over the chest here or an S shape over the back. And there are diseases that follow Blaschko's lines. I'll highlight one as we go here. That's called lichen striatus, which if you looked at this and you didn't really know what this condition was, you didn't know the Blaschkoid distribution, you might think this is zoster, or you might think this is allergic contact, or something else going on here. But this is actually lichen striatus. It's common in children. It follows the lines of embryonic development and actually goes away on its own. It's usually not symptomatic. So it's reassurance instead of, hey, let's do a biopsy, let's patch test, let's do all this stuff. It's just reassurance. Okay, so now let's talk about atopic dermatitis. And I'm not going to bore you with this because I know you know a lot about atopic dermatitis. But what I want to say is it's the itch that rashes. It could be anywhere on the body. And I care much more that it looks like a eczematous dermatitis as opposed to a mimic, then I care that it fits in the classic textbook description of atopic dermatitis. So it's easy when it's the folds, the elbows, the folds, the knees, the cheeks of a child, etc. Those are the easy ones. But if you know it looks eczematous, I'm happy enough with that, because if you biopsy eczema or allergic contact or some other form of dermatitis like irritant, etc., it looks the same under the microscope. Okay, so you're not going to be able to tell what form of dermatitis you're looking at. That's a clinical decision. But if you're trying to decide if it's eczema or psoriasis or eczema or some other mimic, then it's worthwhile to take a biopsy. So now let's look at some things kind of related to atopic dermatitis. The first one's allergic contact. Again, we're not going to dive deep into this, but the history is really everything, and the tip-off is usually it's a really geometric distribution. It's not an organic looking distribution of a rash. It's something that has a geometry to it. Your body doesn't make something in that shape. It doesn't occur in nature that way. So here's an example even of a patient I consulted with in the hospital who is pregnant, and she had a procedure done on her belly, and then they put an adhesive dressing on here, and she came back in with this, and they decided to admit her for a week's worth of vancomycin for a staph infection. And really what she needed was some counseling that she probably has an adhesive allergy, some clobetasol ointment, and go home. So, they admitted her, they gave her like 2 or 3 doses of IV Vanco by the time I saw her. And I said, guys, stop doing that. And they were like, really? They were so nervous to stop it. But this 24 hours after a procedure, staph doesn't do that. That's a vigorous allergic contact reaction. And it can look pretty crusty and yellow and all of that, and it's inflammatory in nature. It's not infectious. So this is what I mean when I say if you're going to biopsy a dermatitis, you're going to get something that looks like this called spongiotic dermatitis. So this is a normal skin biopsy where you can see this nice basket weave. They call it orthokeratosis. This is all dead keratinocytes making up the superficial layer of your skin. And then as you get deeper, you can see these really tight junctions in the more deep epidermal and dermal layers of the skin, versus over here where you see all this ballooning out of the cells. That's spongiosis. You can also see increased eosinophils, the little pink cells, for example. So when you biopsy dermatitis, again, it's not going to differentiate what type of dermatitis. You're going to essentially get /sponge derm from your pathologist. They're just going to say, here's my copy and pasted description of spongiotic dermatitis where I described what looks like this, and then I'm going to give them all of these different differentials of why someone could have spongiotic dermatitis, and it's your job as the doctor to figure out which one of these makes sense for this patient's condition, but it's not going to tell you which one of these it is. So here are some diseases to roll through that's associated with eczema. The first, I showed you this before. So you can see this is on the antecubital fossa. We have erythematous eczematous plaque. So we have eczema here. But we also have these umbilicated flesh-colored papules, and there's this little central umbilication. So this is called Molluscum contagiosum. It's a pox virus, and it's very commonly associated with skin breakdown of the skin barrier, particularly in eczema patients, particularly more in childhood. It happens on opposing skin surfaces, so we call them kissing lesions, where you have it like under your arm here, and then your arm goes down here, and then you get it here. So you can self-inoculate yourself. It will go away eventually on its own, but that can take years. You have to repair the skin barrier, so you have to do something to repair the skin barrier. So don't be afraid to put steroids, even though, hey, that's a viral infection. You still need to repair the skin barrier, and then we can do something to actually target the molluscum itself. And sometimes the molluscum will trigger this vigorous eczema reaction where you see like their eczema is all broken out. So it's a little bit of a chicken or the egg thing, Did the eczema cause the molluscum to be there? Did the molluscum, trigger this dermatitis? I've seen molluscum dermatitis even in people that don't otherwise have eczema, so perhaps there's something to that. But regardless, the thing I like the best is actually intralesional candida immunotherapy. So it's basically the intradermal dilution of what you would use to skin test someone for candida, and if you inject it into molluscum lesions, it's basically like 0.1 cc's, or sorry, 0.3 cc's, and sometimes I'll do multiple lesions to get to the 0.3 if like one lesion doesn't fill up with 0.1. It actually stimulates your immune system to go there and target the molluscum. I use that for warts too. So you can use a Micomod cream, which is a TLR7 agonist. That's my one little board fodder here. So if you're fellows that are interested in board fodder, they like to ask it what toll-like receptor it is a Micomod agonizes TLR7. Okay. But then all of these other treatments are possible, but the one I like the best is intralesional candida by far. Average is once per month for 3 months, and your body turns onto it. It starts to do that. And once you get this crusting and all of that, then the molluscum are on their way out. Here's another one associated with atopic derm. So you can see a little punched out, cropped, right? Punched out, cropped superficial ulcerations with yellowish and serum crusting in the distribution of this child's eczema. So this is eczema herpeticum. This can be quite disseminated. I've seen this in hospitalized patients where it's really all over their body in bad eczema patients. So it's HSV, it's superimposed on the pre-existing dermatitis. You can rub this and just send it for immunofluorescence or viral culture, and you'll diagnose it, but you don't really need to wait for that if it really looks like this. Again, these punched out, cropped, or vesicular lesions, and you treat with acyclovir or valacyclovir, many times IV initially. You don't want to wait and play around with this. You want to get them on aggressive antiviral treatment early, because you want to suppress it at the earliest possible moment. Once it goes really wild all over the body, again, it's a longer, more prolonged, could be more complicated course. So as soon as you identify this, just get them on antivirals. Even if you think that's what's going on, even if you say, I'm not sure if it's impetigo, it looks like this, but it has yellowish crusting, I'm gonna culture it or check it or do culture plus viral swab, all fine. But in the meantime, start the antiviral therapy. Here's a similar one, but a different idea. So this is yellowish honey crusted papules. They're coalesced into plaques on the cheek and on the ear here. So this is pretty classic impetigo. You can also get bullous impetigo, where you get flaccid bulli, so they're not tensed up, they're kind of flaccid and loose, with clear yellow fluid on the inside. And I just highlight one thing: if you do see impetigo, which you definitely will if you're treating enough eczema patients, S. aureus is the most common, but group A beta hemolytic strep is the thing you want to also consider, and it's the reason that you probably want to culture it, because if it is group A beta hemolytic strep, it's not going to change your treatment. You're still going to treat with, a penicillin-based antibiotic for most people, but you want to be aware of post-streptococcal glomerulonephritis because people think of that with strep infection, but if you have impetigo with strep, it's actually more likely that you'll get kidney complications than it is if you have strep throat. So, so you should swab them, make sure you know which of the two you're dealing with, and then treat with an antibiotic. Something like cephalexin or similar, unless it's MRSA. So here's another disease associated with atopic dermatitis. Here is a hypopigmented patch on the cheek of this child. Here's another one. And usually it's in darker skin patients where it shows up a little bit better. Now, the thing with this is I said patch. If I said scaly plaque, this would not be pityriasis alba. So you have to feel this. So whenever you see a rash, you should feel it. Like, I want to feel what it feels like, because this is flat and totally has no scale, and it may be just slightly dry. And this is associated with atopic dermatitis, and it's called pityriasis alba. And you can scratch this with a scalpel blade and look at it under the microscope with a KOH prep and see if you see fungal elements. But if it's just flat like this and it's in an eczema patient, darker skin patient, it's pityriasis alba. It's usually on the cheeks, sometimes the upper arms, and it's just reassurance. Now contrast that with this, which is scaly, oval, or circular coalesced papules into patches. And look where they're distributed. They're on the sebaceous areas. So this is all where the hair-bearing areas are. This is where the oil is. Do you think this little baby has a lot of oil glands going on on their cheeks? Probably not. But along the hairline and along the greasy areas, that's where fungal things like to hang out. So this is Tinea versicolor. This is one I actually scraped myself, and you can see the little branching hyphae and fungal elements here. And you want to be able to contrast these two because one needs antifungal treatment and one needs reassurance. So when you see pigmentation changes, ask yourself, is it scaly? Is it lining up in a certain area? Because organisms are going to go where they can eat and where they can grow successfully. And I almost think the fungal ones look like little petri dishes. Like, if you just forget this is the skin, you look at, like, remember back to microbiology days and there was like petri dishes of things growing? It kind of almost looks like a petri dish, as opposed to this where that really doesn't look like a petri dish. It just looks like flat, white, boring patches in an area where fungus isn't particularly wanting to grow or feed or anything like that. Okay, so now let's move to other diseases you're going to see in the allergy office that are from scratching. So people that are itchy. So here's the first one. And every time I give this talk, somebody comes up to me after and says, I had a patient with this, or I have this, or I have a family member that has this. So I think this is actually pretty common because it's one that most people don't know that well. But as soon as I explain it to them, it's like it triggers that they know someone who has it. So this is a hyperpigmented, very itchy plaque on the scapula. Classically, this will be on the scapula. You'll notice, what do you notice here? It's unilateral and it's dermatomal. When you see dermatomal, when you see unilateral, you're going to ask yourself, what's going on with the nerve underneath? I almost think, if you ever had like a short circuit, like an outlet in your house or a switch in your house kind of like explode, and it like fries the paint, and like chars it and turns it brown. That's kind of what this looks like to me, but this is actually amyloid that's laid down here from all the scratching. So this is called notalgia paresthetica, and typically it's somewhere between T2 and T6 where the nerve gets entrapped as it exits the spinal canal. So we treat this with topical steroids. We also treat it, and what I like treating it with the best is topical capsaicin. That's the active ingredient in hot peppers. So if you apply that over time, it basically desensitizes the nerves. They fire all their neurotransmitters and they basically reset themselves. Some people will need oral Neurontin. Some people will need interventions that are beyond what I would be capable of as a dermatologist. We actually have something done to their nerve. But this is what's going on here. Whenever you see unilateral dermatomal, think nerve, and this is called notalgia paresthetica. The other one I don't have a picture for is meralgia paresthetica, which is usually when the nerves coming around the hips are impinged. So like people who wear like tight jeans, or I've seen that with horseback riders and things like that. But just the bigger concept is just be aware, dermatomal unilateral means nerve. This is called lichen simplex chronicus. This is from chronic scratching. This basically has created this extra layer of epidermis. So remember I showed you that basket weave orthokeratosis, that nice little basket weave pattern on the top of the skin? Well, this is someone who's scratched so much that they basically have a much thickened layer like that. And some of them, because they're turning over their cells so fast, they actually have nuclei up there where they're not just dead, nicely weaved together basket. It actually is having turnover of skin and nuclei where they shouldn't be, but much thickened skin cells here. Now, the take-home point for this is from scratching. To make this go away, you might think, well, I want to just slap clobetasol ointment on this, right? That's a good thought, but before you do that, you need to get rid of all that extra dead shielded skin right there. So I like to use something that's a keratolytic, like urea 40% or ammonium lactate. Probably urea is my favorite. You put that on first, and you let that take away all the extra dead skin cells there. Then you put the steroid on, because remember, your steroid and all your other topical anti-inflammatory treatments, they work on cells by preventing them from creating inflammatory cytokines. So steroids work in the nucleus of your cell, right? A PDE4 inhibitor works internally in the cell. So if you don't get it to cells that actually are alive, that have nuclei, you're just putting an emollient on their skin. So you have to get rid of those top layers, and then you can deliver the medicine deeper down. And one great way to do that is Cordran tape. So there's tape that's impregnated with steroid. So you put it on, it helps put the medicine under occlusion, which means it penetrates better, and it reminds them not to scratch. So I would do something like, hey, right after you get the bath or shower, put urea 40% lotion on every time you get the bath or shower. And then before you go to bed, I want you to put a layer of the clobetasol ointment or the Cordran tape or something like that on there. And if you don't touch it or scratch at it for 2 weeks, I promise you this will go away. And if you do keep scratching at it, I promise I will never make this go away for you. Same idea with prurigo nodularis. We have 2 biologic treatments now that are approved for prurigo, as you know. So we have dupilumab and nemolizumab, which both target the inflammatory cytokines. Now, you might think, Mark, why would those work for this? I mean, they're just picking at their skin. Why would targeting just the inflammatory response, and that's all you're doing, why would that actually take this away? I want you to just conceptualize that prurigo nodularis, these are not like scars. They're not just like keloids. If they were, it wouldn't work. Like for keloids to go away, I have to inject them repeatedly with triamcinolone or something. These are filled with inflammatory mediators. Okay, so for example, you've probably heard of the substance periostin. They check that in the serum of asthma patients when they're doing asthma trials to see how you're doing controlling their inflammation. These are loaded with things like periostin and IL-13 and IL-31 and all these other inflammatory mediators. So these are not just like construction scaffolding. They're actually like a bright orange billboard sign that says, come inflammation, come here, create itch, etc. So these are not just the result of the problem, they're also directly causing the problem. So when you target it with a biologic, you're turning down those inflammatory mediators and preventing them from functioning, and then you're doing something topically or like injectable triamcinolone or whatever to hit them from the top, from the outside, and you can get very, very good results with those medicines for prurigo nodularis. Now, you do need to sometimes address the underlying problem here. So this is a veteran I saw at the VA hospital, and he was having extreme neurotic excoriations from PTSD, etc. This white yellow stuff you're seeing here, that's fat. So he was scratching down below his dermis into his subcutis. So yes, we want to do something to address the itch still. There's still a physiologic thing. Even if it didn't start out as physiologic, it's become physiologic. But you also frequently need to also address any other issues, and this person deserves to have, psychiatric evaluation as well. Okay, so here's a mimic, also not to be, something that I would suggest is not to be missed, which is erythematous crusted pruritic papules. So it's in the itchy category because they're usually quite itchy. And you could see they're in the distribution of the genital area and also on the dorsal hands into the webbing of the hands. I can't tell you how many times I see this missed. The first question you should ask when you see someone who has dorsal hand involvement, genital involvement, waistline involvement, or if they're just coming in and they're itchy, the first question you should ask is, does anyone else at home have this? Because most of the things you're about to diagnose would not be transferable to somebody else. You can't transfer your eczema, you can't transfer your allergic contact. 5 people in the house didn't spontaneously develop an allergic contact reaction to, their laundry detergent or something. This is scabies. Okay, I see this in prisons all the time. They frequently miss it. It causes lawsuits. Patients get quite upset if you treat them for a year with, dupilumab and clobetasol, and then it turns out they had bugs in their skin. And their bugs in their skin look like this. So this is one I actually identified. Like, I scraped their skin, put it on a mineral oil prep, and this is what's burrowed into their skin. You can see kind of reminds you a little bit of like a scabies mite or something else, but they're burrowed into the skin and then they crawl, so you can see like a little track of them. But it can be quite hard to identify when there's all this inflammation going on, where your immune system is trying to react to what's happening. That's what you're seeing. You're seeing a type 4 hypersensitivity reaction to the mite that's in their skin. So you're saying, oh, this looks like a dermatitis, it's allergic contact or something. All you're seeing is the secondary response of what's actually going on here. Itching may persist for 1 month after treatment, so you can use topical steroids and things like that, but you want to treat them first. I very much like oral ivermectin for this, 200 micrograms per kilogram. So for most adults, it's something like 15 milligrams once. They come in 3 milligram tablets, so usually something like 5 tablets taken all at once. You can also do permethrin, neck to soles, wash off in 8 to 14 hours, and then you repeat it a week later. I like the oral because I just tell the patient this is like a nuclear bomb for things that might have infested your skin, whether it's scabies or something else. So we're going to do that. We want to make sure we remove any sources of this. So there's whole protocols for bed linen washing and treating other family members and things like that. But if you don't treat the contacts and you don't treat sources in the house, then they could just get it again. So, but I like the oral approach, and then you can also do the cream as well. So here are some diseases you could mistake for eczema. We're going to start with the face, because the face is probably the most common thing where I see mimics that come in that could be misdiagnosed. So this is one that you should burn in your memory. This is a pretty good example of this. We saw it a lot during COVID. People called it maskne. But what you see is it's basically a combination of eczema and acne. So you get this erythematous eczematous plaques around the mouth, chin. It loves right below the nasal ala here, and it also loves around the eyes. But you also see these little bumps that look like acne, right? So you get the eczema look, but you also get the acne look, and it's around the nose, mouth, chin, or eyes, more commonly of women, but men get it too. And this is an example of the eye here. This is perioral dermatitis or periorofacial dermatitis. The thing with this is most people try like cortisone or something when they come in, and steroids make this worse. We don't know exactly what causes it, but we do know that steroids can potentially trigger it and make it worse. And you treat it either with topical clindamycin or Elidel. You would do both if you did these, but I find that's not effective at least 50% of the time. When I treat with oral doxycycline, which is the same regimen we would use for a teenager for acne, it virtually never comes back. So it's 100 milligrams twice per day for 1 to 2 months. I give them a 1 month supply with a refill. It sounds like a lot of antibiotic, 100 milligrams twice a day for up to 2 months. That's the regimen that we use commonly for acne for teenagers. And you just tell the patient this can make you a little more sun sensitive, so you could burn a little easier, and it can also cause some reflux or heartburn, so make sure you don't lie down for bed right after you take it. But it works. I'm trying to think of a time where it didn't work. Like maybe 1 out of 100, someone will say I didn't fully get better with it or something. But it's very, very effective for this, which is great because the topicals don't work well at all, and it's kind of an annoying thing for people. They don't like that that's on their face. So here's another facial rash that could be mistaken. So this is, again, a seborrheic distribution. So you see the nasolabial folds, you see it around the hairline and in the eyebrows. This one is more widespread. If you take away some of this stuff, you would just see erythematous, greasy plaques in like the nasolabial folds, maybe around the ears, maybe around the hairline. But conceptually, it likes areas that are sebaceous. That's the seborrheic distribution. So, and classically, you talk about greasy scale. So, like, see the scaling here? It kind of like has a grease to it. It's not like dry and flaky. It's more greasy because it's in the areas of oil production. You could see it in children where you call it cradle cap. And it's thought to be an inflammatory reaction to the normally occurring malassezia. So basically, I tell patients, everybody's skin has naturally occurring yeast on it, and some people's skin decides doesn't like it there and starts to get angry and inflamed because it's there. You can treat with ketoconazole 2%. You can treat with ketoconazole plus steroid, which is the classic regimen. So something like ketoconazole 2% cream or shampoo. If you use the shampoo, you can use it as a wash and in the scalp, or you can just apply the cream, plus something like Desinide. But if you want to use the newer thing, then topical roflumilast, which is called Zoryve, 0.3% cream, which is FDA approved for monotherapy. So you don't need the antifungal. This is approved for monotherapy. It's a topical phosphodiesterase 4 inhibitor. It's also FDA approved for atopic derm. It's also FDA approved for psoriasis. And they have a foam version. And I like the foam because it rubs in and disappears. And foam is really good for hair-bearing areas where you want to rub it in and make it disappear. So scalp psoriasis, you can use it for. Sebderm, you can use it for. And the nice thing is, if you're not sure if you're dealing with psoriasis or sebderm on the scalp, which happens a lot, this treats both. So you can just give them the foam and you're in pretty good shape. So here's another facial rash that sometimes gets misdiagnosed as other things. This is erythematous papules on a base of erythema, classically on the cheeks, but can be other places like the arms. You can see it has a combination of papules and patches. So I hate the terminology maculopapular because it's like a terrible description. But you do have both here. You have patches and papules. This is the history is important. So you'd say, well, tell me about this rash. When did it start? How does it happen? And she would say, every time, we go on vacation to Mexico in April for the first time, she gets this rash. And this is called polymorphous light eruption. It classically occurs during the first 3 decades of life and usually in the spring and summer during the first, major sun exposures. It's polymorphous, meaning it looks different on different people, but it's monomorphic for a given individual, meaning hers will look like this, but other people who have this condition, it can look slightly different. And you basically just need sun protection avoidance. I usually advocate for pre-treating. If you know that is your pattern, then you apply an anti-inflammatory like a steroid or one of the non-steroidals prior to those exposures, in addition to using good sun protection while you're there. Sunscreen, especially the mineral-based ones, are usually best, like zinc or titanium, because it reflects the UV radiation off. And then if you were thinking of facial rashes, you probably wondered when I was going to get to this. And if you contrast that with this, you might have said, oh, Mark, that looks like a butterfly rash. Butterfly rash is just because those are like the protruded areas of your face. But then where else is it? And does it have this greasy scale and all of that? Contrast that with the classic lupus rash, where you can see, first of all, it's concentrated. It doesn't care about sebaceous areas. It's concentrated on this butterfly distribution over the protruding areas of the face. It also has this dry, silvery scale on it. But the real thing is it has a dermal component. So if you feel it, these are going to feel juicy. And if you look at this under the microscope, you can actually see these pits that go down into the deep dermis. So when you're looking at something like autoimmune rashes like lupus, that's where we use a punch biopsy tool because we want to get down to the fat layers to see what's happening with the fat and the surrounding blood vessels, versus most things where a shave biopsy is fine. You don't have to go deep because you're just looking at the superficial. So this is one where the tip-off is butterfly rash, right demographic, a person, middle-aged female, but also it's dermal when you feel it. So now let's talk about nummular dermatitis. So we see lots of circular rashes. So nummular dermatitis is erythematous nummular plaque. They're circular, but you'll notice this is filled in here. These are pretty filled in. So a nummular dermatitis or coin-shaped eczema, nummulus literally means coin in Latin, I think. Other words, discoid eczema, which is also kind of a way of saying circular. So this is frequently confused with ringworm, and the reason it's important is they're treated totally differently. And if you put topical steroids on a fungal infection, it makes it worse. If you put antifungal cream on nummular dermatitis, nothing bad happens. So which one do we think we should err on the side of caution with? If we're looking at a circular rash and we're not sure what it is, should we put fungal cream on it for a few weeks, or should we put steroids on it for a few weeks if we don't know what we're dealing with? I would put fungal cream on it for a few weeks because it's an emollient. Nothing bad's going to happen if it's nummular. But if you put clobetasol on a fungal infection for a few weeks, you could do something bad that I'll show you. Here's another circular rash. So I intentionally chose the head of the penis because this is the most classic place for this. And this is a dusky purple to brown plaque. It occurs on the same location each time. And if you get a good history, the patient won't know this, but if you ask them, this is fixed drug eruption. It occurs 30 minutes to 8 hours after the drug administration, and it resolves spontaneously 7 to 10 days later. But it can be itchy, painful, etc. It's not totally comfortable for the person. And the two most common things I highlight are antibacterials, like tetracyclines. So if you put that person on doxycycline for their perioral derm and they develop this on their head of their penis, you cause them to have a fixed drug eruption. That's okay, but you want to identify it. Or NSAIDs, so something like ibuprofen is a really common one for this. Even Tylenol I've seen. So these are not, these are very common medicines where you will see this. Treatment's just avoidance. If you want to be sadistic, you can oral challenge them or patch test them and it will develop again. But usually you can diagnose this just with clinical history, and then you just treat it with nothing or topical steroids if they're uncomfortable. Now contrast that with this, and this is one again where history is important, but also feeling it. So I keep coming back to feeling the rash. This actually has, you feel it has texture, that's a plaque. This is a patch. This is hyperpigmented patch. That's a post-inflammatory hyperpigmentation. Who knows what was there before? I say that's the paw print of what the animal used to be. Maybe it was annular dermatitis, maybe it was something else, but that's what the body leaves behind. And the melanocytes get revved up and produce pigment. It will go away, but it can take up to a year. There is laser, there is topical creams like hydroquinone creams that can help with that, but you can do nothing and it'll eventually go away. Now contrast the annular dermatitis. This has a obvious clearing in the center, right? No one would argue that this is mostly filled in. This has a cleared center. It has a little bit of a scaly raised border. And where is it? It's on the back of the neck. It's areas where fungus wants to feed. This is ringworm or tinea corporis. If it's on the foot, it's tinea pedis. If it's on the hand, it's manum. If it's on the scalp, it's capitis, just naming conventions. And if you scrape it, and I know this might sound intimidating if you guys aren't like used to looking at things under the microscope, but you literally just take a 15 blade scalpel, scratch it, take that material, put it on a slide with a drop of KOH and look at it under the microscope and see if you see these little branching fungi, hyphae elements, you know, or you look for the macaroni and meatballs or spaghetti and meatballs, it's with tinea versicolor. So it's not very difficult, but if you're not comfortable doing that, this can be diagnosed clinically. I mean, I would look at that and say, I don't need to waste my time scraping that and charging someone money for that. Let's just diagnose it. And if you're not comfortable, you can also just buy some fungal cultures. They're like little tubes that have the media in them, and just leave them in your office. You have 15 scalpel blades, and if you see this, you just scratch the periphery of it and just take that whole scalpel blade and just put it right in the fungal media, send that off for fungal culture, and it'll grow or it won't grow. Kind of like a strep swab, except you're scratching. You're just scraping the surface of the area. And you don't want to scrape the middle. That's not where they are. You want to scrape the periphery. Now, if you do put clobetasol on a fungal infection, you can cause a Meioki's granuloma. That's where you drive the fungus deeper down to the skin. You can see this is kind of shiny looking from all the steroids they put on. And then the fungus is no longer superficial. It's no longer in a nice ring. It kind of went wild and is now a Meioki's granuloma. So instead of a few weeks of a topical antifungal, you bought them 4 to 6 weeks of an oral antifungal, but by putting a potent topical steroid on a fungal infection. Now contrast all of these with this other circular lesion. So this is has no scale. It has a dermal component. See how this is raised? And if you feel this, it feels deep. It feels like there's a dermal component to it. It's not just superficially on top of the skin. And I gave you one that's a classic of where it would be, which is the dorsal hand. So no one would fault you if you thought this was ringworm and you gave them antifungals, but it's not going to get better. And if you scrape it or culture, it's going to be negative. You'll notice it doesn't have any scale. And is this really an area where fungus would typically like to grow outside of some inoculating factor? Like, yes, you can get tinea manum, but like, you know, were they doing things that would result in that? Versus the common thing that we see all the time, especially on the dorsal hands, which is called granuloma annulare. So again, no scale, not usually pink or red in particular. These are more flesh colored. If you look at this, kind of has the flesh colored look. And it's benign. It's a granulomatous inflammatory condition. There's no infection there. If you biopsy it, it looks pretty classic under the microscope. This is something you can easily diagnose under the microscope. Dorsal hands is the most common. You can get it all over the body, not just in that one location. I've seen people have it more widespread. You can use things like TNF inhibitors, like adalimumab, you know, Humira. It's not FDA approved for that, but it's something that you can do with varying results. But why it's distressing to people is they don't know what it is, and people think that they have an infection and that they can't wrestle, or they don't want them as their teacher. It's like it can be a kind of a stigma thing, so you want to make sure you diagnose it and educate people. And then here's another circular one. This is erythematous, totally filled in plaque, but you'll notice it has all of this scale and yellowish stuff associated with it. It's also on the dorsal hand of an older person, and especially if it's surrounded by a bunch of other sun damage. This is actually a skin cancer. This is squamous cell carcinoma in situ. So the tip off here would be sun exposed areas. It's not raised up or dermal. It doesn't have some peripheral pushing border of scale like it would in tinea. And it's growing and enlarging, and they don't know where they got it from. And a biopsy would show that it has cancerous cells there. Here's an example of another mimic of atopic derm, psoriasis. So these are well demarcated erythematous salmon-colored plaques with white or silvery scale. See how well demarcated this is? That is a big tip off that this is psoriasis and not eczema. Okay, so look at the geometry and how defined it is. You'll also want to look at their nails because they can get things like these oil spots, these yellowish or brown looking spots. You can get ice pick pits where it looks like someone took an ice pick and made little pits in their nails, and you can see it loves around the nail plate here at the base of the nail, where the nail grows out from. Their psoriasis is being triggered from there, so the nails can help distinguish that. Here's a common distribution. It's basically the opposite of eczema. So eczema is the fold to the elbows, the fold to the knees. Plaque psoriasis is the back of the elbows and the front of the knees. So the flexural surfaces are atopic derm, and the extensor surfaces are psoriasis. It loves the ears, it loves the scalp, it loves the sacrum and the genitals and the belly button. If you see some of these areas, like you see scalp, belly button, genitals, or sacrum, you very likely have psoriasis, not eczema. So nothing's 100%, but very well demarcated, some of these other features. And then you can have other distributions of psoriasis. Guttate means teardrop shapes, so commonly in kids and very commonly triggered after a strep infection. So you see guttate, the first question you ask is, have you had a strep infection recently? And then there's also an inverse distribution. How many, if you're being honest with yourself, I know I would say this when I first started learning dermatology. If I saw this, I would think, oh, they have a yeast infection, right? This is intertrigo. This isn't some sort of allergic contact, the underwire of their bra or something like that. No, there's an inverse distribution of rashes, and this is the inverse distribution of psoriasis. So if it's bilateral, it's symmetric, and it still has the appearance of psoriasis, the white silvery scale, the well demarcated lesions, etc. This is inverse psoriasis. This is not any of those other things. Now let's go over diseases not to be missed. The first are these targetoid papules, erythematous papules, on the palms of this, I think he was 21. This is a patient I saw. So something on the palms should trigger, hey, I need to do more evaluation here. I need to think about this. There's not that many things that cause rashes on the palms like this. If you see one, it's probably something that you shouldn't miss. This is called erythema multiforme, and it is a reaction to an HSV outbreak in the vast majority of cases. It can also be a reaction to drugs, but HSV is what you should think of. And the take-home point here is if you see erythema multiforme, again, these targetoid lesions on the palms and soles, you treat for HSV even if you didn't see an HSV outbreak present. What you don't do is give them steroids. Everybody wants to give them steroids. If you give them steroids, it will potentially flare the HSV infection again versus treating them with valacyclovir, acyclovir. So you don't give steroids. And if it's it can also affect the mucosa, by the way. So you could have palms and soles, but you could also have lips or membranes, when then it's erythema multiforme major. Now, this is one that hopefully no one would miss, but when you see mucosal involvement, if they have the targetoid lesions on their hands, okay. But if you see mucosal involvement, you should be asking yourself, why is this not SJS or TEN? I don't have time to do a deep dive on this, although I really do love this subject, and it's one of the most common reasons for lawsuits in the dermatology and allergy world, because someone got a drug, it almost killed their relative, or it did kill their relative, and they're pretty upset about it. And people who miss the diagnosis, they're upset about it, and people who prescribe the drug, they're upset about it. So hopefully you can identify Stevens-Johnson and TEN. It's a spectrum disease in most textbooks. SJS is less than 10%, TEN is greater than 30, 10 to 30 is an overlap. I don't totally agree with this. And sometimes it's in evolution, but if you actually look at biopsies, Stevens-Johnson is much more cellular, is the picture that you see, whereas TEN is relatively acellular. You just see a ton of necrosis and epidermal damage. And maybe it's when you biopsy along the spectrum of the disease. But regardless, it's a little bit irrelevant which one you're calling it, as long as you know what this is. So I'm going to skip ahead a little bit for time here, but the worst mucosal things you'll ever see in your allergy careers are Stevens-Johnson and TEN. And you see people, they get missed because they say, oh, they have a UTI even though the UA is negative, or they have a pink eye even though it doesn't look like pink eye, or they ignore the skin rashes. Once you see mucosal involvement for something that you're being consulted on, be concerned about Stevens-Johnson TEN. You know about the score 10, and then here are the common causes. These are things you should burn in your brain, especially the medications, because people can assume that it's an infection. Like, I've seen it where you get admitted to the hospital and they pick you or something, and they're like, oh, the kid was coughing and looked sick and had a fever, so they probably have mycoplasma. But then they keep giving them their ibuprofen or their Tylenol because they have fevers, but the fever is actually a sign of their SJS-TEN. It was actually triggered by the ibuprofen. Acetaminophen, by the way, also has warnings about Stevens-Johnson TEN. So you don't continue any medicines. When someone comes in with Stevens-Johnson, unless they absolutely need the medicine to support their life, you do not continue their medicines. Like if they had seizure medicines at home, if they were taking Tylenol, if they were taking, don't just casually write, Tylenol, for fever greater than 100.4, like on demand, the nurse can just give it. You could be actually worsening their TEN. The fever is not going to harm them, especially if they're really sick. But if the medicine is actually triggering their disease, very difficult to defend that decision. So you withdraw the offending agent, obviously supportive care. There is lymphocyte transformation testing to try to confirm an agent if there's multiple. It's not 100%, of course, but if you need to do it, you can consider it. What I really want to advocate for, though, is TNF inhibitors. There's mounting evidence, very good evidence. I wouldn't say very good. There's not big numbers in double-blind placebo-controlled trials, but in the case reports and case series that you see, TNF inhibitors is what I would want. Give me a dose of etanercept or adalimumab first when I walk in the ER, and then let's ask questions later. I can't tell you personally how many patients I've treated where statistically and just by experience, that person was supposed to get really sick or not walk out of the hospital, and a few days later they walk out of the hospital. Also, don't be afraid to observe these people for a while. They can look a little better and then get worse. Don't just discharge them because they're better after a day or two. Watch them, give them the TNF, support their care, make sure that they're on the way down, and make sure you've withdrawn any offending agents. And then here's another one not to be missed. These are erythematous well-circumscribed plaques. You might be thinking psoriasis, but it's not in the common distribution for psoriasis. And you also can see lymph node involvement. You can see enlarged lymph nodes. You could see more dermal involvement, so-called tumors, and it's typically classically in the bathing suit distribution. So an atopic derm patient that's not getting better, think about CTCL. Bathing suit distribution can require multiple biopsies with a good pathologist to make the diagnosis, but this is CTCL, and you can get erythroderma from it as well. And this is what CTCL looks like under the microscope. So you can see what we call too many for too little. See all these little, like all nucleus cells, like it's just all purple, there's no cytoplasm. These are all T cells, but they have no reason to be there. There's no infection going on. There's nothing going on here, but there's too many cells for too little inflammation, and they can even create little Potriers microabscesses. These are sterile, like there's nothing in this. There's no bacteria. They just clump up together, and these are homogeneous cells. They're all of the same lineage. Talked about herpes zoster. Here's that dermatomal distribution. You could see this before the vesicles. If you're a really good diagnostician, you'll see little pink, just a pink faint rash in the dermatomal distribution. You'll say start Valtrex. Did you have chickenpox as a kid? Yes, you're in the right demographic. You weren't vaccinated. You're getting valacyclovir, and I'll ask questions later. If you're really, really good, they'll just show you the distribution that they're feeling the tingling sensation in, and you'll just start it before they even get the rash. And then I want to show you bullous pemphigoid, another one not to be missed. Older adults, okay, like 60, 65, 70. ask yourself, is this really CSU? They have urticaria, but they're an older adult. Maybe they're just in the urticarial phase of bullous pemphigoid here, and they're going to develop blisters later. Because the treatment, well, there is one overlapping treatment. So if you're not sure and you put them on dupilumab, that's FDA approved for both conditions now. So I guess I would advocate for that. And it can also help avoid this patient from being on long-term steroids or needing more advanced therapies. This is board fodder stuff, like what it, the antigens here against the membrane. And then I want to show you something that you're going to see a lot that can look, maybe you would think this is sebderm or eczema or something like that. This is just an older gentleman who has a lot of sun damage, and he has these scaly pink papules. These are precursors to skin cancer called actinic keratoses. We freeze these things, or we do some other form of therapy like skin peels or topical chemotherapy creams to destroy this. But don't get confused and think this is somehow an inflammatory rash. If it's an older adult, it's on their arms or their face or their upper chest where they got a lot of sun over their life. These are actinic keratoses. A quick word on topical steroids. This is my rule. I call it the Serota rule. Hopefully it's my legacy when I die and someone writes up something about Mark Serota contributed to the field. They're going to say the Serota rule, okay? The Serota rule is you can't go from diseased skin to damaged skin, meaning if you're treating something like nummular derm and you get to normal, if you just stop, you will not get to the point of creating atrophy and striatal telangiectasias. Those occur because people continue to put these things on normal, healthy-looking skin or surrounding skin. But you can't go from disease to damage. You have to pass through normal. And here's my little strategy of steroid use. So low-potency desonide up to high-potency clobetasol and everything in between. Keep it simple. And then there's obviously a bunch of non-steroidals now that are really good. Zoryve I highlighted. I'll also mention Opzelura for atopic derm and vitiligo, and I'll also mention Vtama for psoriasis and atopic dermatitis. So it's actually quite a number of very good non-steroidals. So if you're not familiar with those, I would suggest you get familiar with them. Less common to be able to use them maybe in an academic setting where it may be harder to navigate, but in the private world, in a private insurance world, it's pretty easy to actually get these things. So with that, I left a minute for questions if you